So, good evening, chairpersons and my dear colleagues. This is my topic. Low risk TAVR is a ridiculous idea. Well, I've decided after getting this topic from the beginning that I'm not going to initiate any debate on this. At this age of artificial intelligence and this wonder app called ChatGPT, I think anything is feasible. Any idea which is at present is ridiculous. Over the period of time, it gets evolved and going to be accepted by the scientific community. So basically, I'm going to use this opportunity today to basically find the pros and cons of TAVR and to compare with a SAVR. And for that, I've got this presentation, and this presentation consists of publication in JACC in 2021, and it shows that it is a very, I would say, a robust data, because this has been collected from patients who are having a study comprised of 3 randomized clinical studies and 3 non-randomized prospective studies. So it's a big data. And the things which has emerged out of this is, number one, is that low risk TAVR is an accepted idea. There is no doubt about that. But there are certain unanswered questions which needs to be sorted out before we are going to accept it universally. So these unanswered questions are: what is the safety and effectiveness of TAVR in bicuspid aortic valve? Number one, if we have to do a coronary angiography in these patients, what is the way of the future coronary access? Number 3, we are talking of transcatheter heart valve. Then what is about their durability? And then if by chance after a TAVR, we have to do a SAVR, then what is the difficulties the surgeons are going to face as far as the surgical explantation is concerned? Next will be, with these patients, we can have associated conditions. When we are talking of BAV, there is a chance there can be ascending aorta dilatation, because there is a term bicuspid aortic valve aortopathy. So are we ready to sort it out? What about a severe mitral disease or a severe coronary disease? And lastly, the safety and feasibility of future valve-in-valve TAVR. So all these issues we'd like to discuss, but because of a very short time constraint, we will just go through it quickly. This bicuspid aortic valve, there was a publication, it's a review article appeared in Circulation in 2021. The thing which emerged from this article, that tricuspid aortic valve TAVR and bicuspid aortic valve TAVR are not same. In the cases of bicuspid aortic valve, we face a lot of difficulties, and there is a low risk, but more risk than a tricuspid aortic valve TAVR in terms of more stroke, more chances of PPI implantations, annulus ruptures. These things are there. Now, why it is? It's very easy to understand that bicuspid aortic valve's anatomy is fairly distorted. There is a classification called Siever's classification which has been used. And from this study, they find out very clearly, if it is a type 0, you should go for a TAVR. If it is a type 1, you should not touch it. Rather, you send it to a surgeon. If this bicuspid aortic valve has any suggestions of aortopathy, send it to surgeons. So finally, it comes down to a heart team to take the final call. Next issue is another very, very conscientious issue, that what happens to a TAVR patients for in future where they have to undergo a coronary angiography. This paper is very recent. It has come in 2023 in Eurointervention. When I was going through this paper, what we find out that this is the prevalence of CAD. This is across a lot of famous trials for TAVR. Now you can see the prevalence is pretty high, 60 to 70%. But why it is? you people will be able to answer very easily, because this is done on a high risk group. So all the octogenarians have a chance to undergo chances to have a coronary artery disease. But when we are going to extend this TAVR in low risk young patients, still the chances of coronary intervention will be very high, because it is a huge, long lifespan. So they can have a progressive coronary artery disease, they can have ACS in their lifetime, they can have a CTO where you have to get a coronary access. Now, here this paper also highlights that fortunately, if the patient has a SAVR and you have to do a coronary angiography, for all of you interventional cardiologists, you have realized the game is very easy. I think you should thank the surgeons, because what we do during the surgical procedure, we thoroughly resect all the leaflets, number one. And when we put a surgical bioprosthesis, the commissural level which is there of that bioprosthesis, we aligned with the native commissure, so that the coronary ostia is now free, and for you to do a future angiography becomes easier. But when it comes to a TAVI, the things is very different. Here, there are many issues. You have to know about the transcatheter heart valve's leaflet height. Then there are certain anatomical issues, like you have to know the sinus, what is the small or big, what is the STJ junction, what is the height of the coronaries in comparison to the commissures. And even the things becomes more murky and complicated when the patient has already a SAVR followed by a TAVR, or a TAVR followed by another TAVR. Then the things become even problematic, because these are the problems you can face in these patients. In this, if you have got by chance a commissural misalignment, then the chance of not engaging the coronary arteries is 50% of the cases. So it's a huge problem if you have landed into this situation. So now this things shows that a patient who has got a TAVR, you are going to face a problem with RC engaging, taller stent frames, ceiling skirt, small sinus of Valsalva, low coronary heights. So these are the problems you are going to face. But now the surgeons as well as the cardiologists are becoming smarter. They know how to tackle these scenarios, and they have to do a coronary angiography. So they have come out with various ideas, and those ideas are like they can do MDCT scan, know how the coronaries are placed, and figure out the strategy. Next is this Kaplan-Meier curve for the durability of this valve. I have just included one slide, and that is enough. If you can see in this slide, this is the probability of the structural valve degeneration in cases of a SAVR as cases of TAVR. Now, you should not be amazed, because SAVR and TAVR are the same bioprosthetic valve. So they are subjected to the same sort of problems. So this is not a good news in the sense that the recent TAVR valves, some modification, some design changes are required, that they should be sustaining into the system more than a SAVR valve. That is expected. This is the scenario. Next is the problem is when we are considering a patient of TAVR, and this patient has got certain problem which cannot be sorted out by valve in valve TAVI or TAVR next. There's no way out. We have to do a surgical explantation. Now the question is, what happens? Now this is a scenario when we see in a patient, when the patient has a TAVR earlier and this patient is taken for a surgery. Now, there is a very important publication which I have included, but somehow it has not appeared. It is in the STS database and again published in the Journal of American Cardiology. So there what they find that the valve type called this self-expanding nitinol valve. This is the core device. It's very notorious. Why? Because this valve gets so much adherent to the aortic wall that it becomes a nightmare for a surgeon to explant the valve. And what is the end result? That we have to do a complex aortic root repair, number one, and this will prolong the surgical time, and there is a huge mortality in the series. That means TAVR followed by SAVR, the mortality comes around 17%, which is not acceptable. Where a SAVR followed by a redo SAVR, it is less than 5%. So this is something you can see in this picture. A surgeon is literally struggling to explant the valve from the aorta. So this is another area which needs to be looked upon. So lastly, we should also consider before coming into this that concomitant conditions. What are these? Like if we are discussing about a bicuspid aortic valve, and if the patient has got a 45 centimeter more dilatation, are you going to do TAVR? There's no answer. You cannot. A patient has got a critical coronary artery disease with a high syntax score, left main, not possible to do a TAVR. And a severe mitral regurg, again, these cases will be referred back to a surgeon. And lastly, we are going to examine this issue, the valve-in-valve TAVR. You can see there are three possibilities: SAVR, TAVR, 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 SAVR, TAVR, and all the way TAVR. Now, is this possible? Yes, when you are going to extend it for a young patient, due to his huge life expectancy, you are going to have this three procedure done in his lifetime. And out of this, if you try to figure out, this possibility is SAVR followed by a TAVR is there, must, and a TAVR and the TAVR followed by a TAVR is plus. So these are valve in valve. Now I have again considered two papers. One, this paper is basically dealing with a surgical aortic valve replacement, that is redo, versus a surgical aortic valve replacement in valve TAVR. The good thing about this paper is the result of these both papers are very, very similar. So that is very encouraging for the TAVR groups which are being advocated. These are some of the valves which has been ex vivo explanted. So inside there was the TAVR valve, and outside you can see the surgical bioprostheses are there. Valve in valve TAVR, valve in and TAVR, when the TAVR, you are going to put another procedure in that means TAVI versus TAVR. In that condition, this paper is also very important to consider. This has come from Switzerland, and they have highlighted one very, very deadly complication, that is the risk of coronary obstructions. Now, what has happened that the data which they have accumulated with valve-in-valve international data registry, they found in this group, there is a very disturbing coronary obstruction incidence up to 2 to 3%. So this has led to rethinking what has to be done. And for that, they have again developed a lot of strategies. One is that they are using multi-detector CT scan to figure out how to protect the coronaries when they are doing valve-in-valve second time TAVI, number one. They have also improvised a new strategy called Basilica, which is basically bioprosthetic aortic scalloping intentional laceration. This is to prevent the coronary artery occlusions. So these strategies are adopted so that TAVI, valve-in-valve TAVI is being continued nowadays with a lot of safety. But lastly, I'm just summarizing. These are the issues which are remaining, which I have been discussing. And finally, I would like to suggest before concluding the talk, there are three things we need to think about. First is that we should respect the individual patient's anatomy, number one. Number two, we should tailor-make the strategy accordingly. Number two is that we should think about this severe aortic stenosis lifetime management. If we are considering a patient undergo 3 times TAVI in Indian condition with our economy, we have to rethink our strategy because economic constraint will come. And lastly, we have to also accommodate a lot of new surgical approaches. Why? Like what we are calling rapid deployment valves, resilient valves. Some mechanical valves are coming with low intensity anticoagulation. Why I am asking? Because this will be added in our therapeutic armamentarium along with TAVR for the lifelong management of severe aortic stenosis.
Thank
So
you.
with that, I conclude. Thank you
Thank you for finishing in time.